Welcome to the Rogue Treatment Podcast. James, you're telling jokes today. You look like you're in the mood.
I am in the mood.
We've got
Harry.
we've got a great guest today. Someone who I think we'll talk about a lot of topics that are going to challenge people's thoughts. We've got some great questions to ask. I know, James, you were keen to ask some rogue questions. And we're talking about some off air.
Some of it was off air.
Yeah.
Hopefully we can keep going through it.
So we thought we better just get started, get the cameras rolling. So, Michael, we welcome you to the Rogue Treatment Podcast.
Thanks for having me, guys. It's a nerve-wracking experience. We'll get through it. We'll be all right.
Nah, nothing to be nervous about.
Nothing?
Nah, not at all.
James gets. If you're a little bit nervous, don't worry. James gets a little bit nervous too.
Yeah,
you know when he fires up, he'll go red.
Yeah. Okay.
And then when he's red, then you're like, sweet, I'm so comfortable.
I'm good now. I'm all right. Okay. That's the tell. That's the sign. Done.
You'll see it. It's like literally bright red. Thanks, Harry. Tell him the telltale sign.
We've got first off the bat. That's right.
We've got a few things to go through. We want to sort of see how this goes. We're going to talk about some supplements, some natural remedies, some your work in pharmacy and everything. But before we start, let's talk about a little bit of your journey and tell the listeners about what sort of brought you onto the podcast today.
At first, you didn't tell him he's a pharmacist.
Yeah,
he's been in the industry a while. He's got some really good information.
Can you just remember who's the host here and who's the co-host?
They said both of these are hosts. We're in the same picture. So
there's my own camera here. No, okay. Yes.
Carry on. Well, it's important that they get to know who this guy is. He's a pharmacist, been in the industry for a while, and we wanted to talk, obviously, like you said, about those kind of topics. But you didn't say who he was.
Well, I thought Mike would be able to manage that part.
Well, that's an manager.
James just likes talking. So you've got to be careful there, Michael.
Here we go.
So if you're nervous, I hope all those nerves have gone now.
It's fired up already.
Now you pissed me off. No.
Yeah. I'm just some bloke off the street. I'm not really a pharmacist. No. Pharmacist for 5 years now. Did my registration through peak of COVID, 2019, 20. Pharmacy was never really my first foray. I went into medicine. I had a medicinal chemistry degree, which was more the drug design, development, big pharma side of things. Never ended up getting a job in that because you needed high qualifications, further study, whether it be research, PhD, whatever it might have been. Wasn't ready to do that. So I thought if I couldn't sell the drugs, next logical step would be make the drugs. Went through uni, fell in love with the industry, and here we are. So
yeah, nice.
Very good.
Well, thanks for joining us.
Thank you. Thanks for having me.
Well done.
Now we've got some background into what he does.
Does your wife call you a gaslighter?
She does, but let's not go there.
That's a separate podcast.
It's not one of our core topics. Business, sport, health.
It's okay.
Nothing about relationships.
I'm with your ads. So wait, you said that you fell in love with it. What sort of where'd that come from?
I think the number one thing for me that really stood out is when someone comes back to me and says, you really helped me, or you really helped my kid, thank you. Whether it be an emergency situation on a Saturday afternoon, doctor's closed, or first-time parents coming in going, I don't know what the hell to do. I can't get a hold of my doctor. Can you help me? Or, whether it be like a sting, or like a jellyfish sting, or something small, but someone just coming back to me saying, that really helped. Thank you for your advice and time. I appreciate that. So
yeah, awesome.
That's something that I find really rewarding in the industry.
And you mentioned obviously like the first idea was to get into the making of the drugs kind of thing, and then maybe going to work for a big pharmacological company, and then obviously now you're on the other side of the fence. So there's a difference between being like in the service side of it versus the making of it. What do you, and apart from like you just mentioned, there's the individual part of it, but what drew you to the big pharmacological side of it first?
I always had a passion for chemistry. I was one of those nerds in year 12. There's physics wasn't my thing. Biology, I thought, sure, this is just sort of encompasses everything. But chemistry, I had a really good teacher and sort of fell in love with that subject. So I thought, okay, I enjoyed the lab aspect. I enjoyed, we had a couple of mock, manufacturing of basic medications and things like that. And I thought, hey, this would be pretty cool as a sort of career. Everyone tells you follow your passion when you go to uni. That's a lie. You don't do that, and do something logical. Think with your head, kids. Don't. But yeah, that's sort of I went down that path, and unfortunately, it just unraveled itself. And
nice.
here we are. But that's right. It is what it is. So
Yeah,
here now.
100%. That's pretty cool. Very good. And then in terms of like where you see that divide now, we were talking about obviously there's the service part of it, and then there is, the making and the funding of making drugs as well. Where do you see the big divide currently now that you're on the service side of it and helping people and, filling prescriptions? What do you see as, a challenge, or do you see any, like I said before, divides between those two currently?
I think any job, customer facing or patient facing, is going to be challenging. Everyone's got a different attitude. Everyone's got a different perspective on things, whether it be money rich, time poor, money rich, whether it may, it's always a different dynamic. So that will probably be the sort of biggest challenging part for me. I'd take a very neutral approach. I don't think you can go anywhere hot-headed. Like, you can't go in with a preconceived notion of someone. Unfortunately, it does happen in the industry, just with the medications we deal with, so whether it be narcotics or opioid replacement therapy or things like that, you can't have that sort of negative connotation towards people. You just have to be neutral and deal with it. It is what it is. So.
Yeah, absolutely. And then, obviously you'll see a whole range of prescriptions, right? And for a whole, shitload of different things. Like, what are some of the things you're picking up on? What are some maybe common themes or reoccurring themes that you're noticing? And then is there anything there that kind of sticks out that you're like, why is this happening?
I think we touched on it earlier just before the show. Antidepressants have skyrocketed. I don't know if it's ease of access or prescribing trends are differently from the sort of the doctor's side, what their recommendations are and their guidelines are, or it could be just the swing post-COVID. I think lockdown affected people dramatically. Mental health has sort of become more aware. So I think I'm seeing that trend skyrocket. Antibiotics, they're your mainstay. Everyone gets sick. Everyone's, cholesterol, blood pressure. They're very dynamic. I find that trends will change over time, and we have to sort of, we can notice that certain medications will start getting dispensed more frequently, whether that be, a prescribing guideline, or a doctor's gone, or a medical rep has gone to visit a cardiologist. So that's a separate thing altogether. But we do notice quite a dynamic flow of things.
So just touching on that, obviously, you're going to see antibiotics. They're your bread and butter. That's I guess, a big part of pharmacy, right? But then there's the treatment of diseases, right? Like you said, mental health and, whether it's cardiovascular disease, all those kind of things. When you see a change in those trends, like obviously it's increasing mental health, or there's a change in the type of medication that is now being dispensed for cardiovascular disease. You touched on, like, it could be that the medical rep went there, whatever it is, right? What, at the end of the day, what do you think drives those change in trends?
I think money at the end of the day.
Money?
I think so. Not from our end. I think whether it be Big Pharma, spends $400 million developing a new drug and it shows XYZ improvement in cardiovascular. I think doctors are going to go for that. They want good outcomes.
Yeah.
There's some pretty heavy medications that are specialist limited. We don't see that often, but when you see someone having that medication, you're like, okay, shit.
Yeah.
They're at last line heart failure, for example. So I think it is education, whether it, or I don't want to say influence, but it falls under the education.
You can say influence.
It is the Rogue podcast. Yeah, it is, I think so. Like, conferences happen all the time around the world, and trends and things just come up all the time. And they change left, right, and center. So it could be at that space. It could be, there is marked improvement of XYZ markers. So we don't see all that. I mean, we can look into it. The papers are there, but I think we just notice the end product and.
Yeah. And I think that's the important part is here, you obviously see the end product, right? Which is, the changes of the client, right? Sometimes I feel like, I'm going to have a dig at doctors here, but it's not my intention, right? But doctors are there to give a solution to a client, right? And if that solution is pharmacological, sometimes it goes a little bit beyond, these are the levels, this is these are the results. Yes, that's good that it's working that way, but a lot of the time there may not be that high level of follow-up. It's like, take this drug, the client might continue to take it, but there isn't necessarily that it's having the impact that it's intended, right? Whereas you would see that. You would see, okay, you've been coming in for this amount of time and nothing's really changing, right? Do you kind of, is that a trend that you pick up on a lot there as well? Or, am I being a little bit, negative in the impact that doctors are having here?
No, I do see that. I think pharmacists do see that in general. I think if you're on 12 different medications, something's going to give. Yes, your blood sugar's down, your blood pressure's controlled, your LDL levels are fine, but you got to think of everything has a side effect. So is that having a further impact? So you might see myopathy, you might see kidney disease develop, you might see glaucoma because, yes, this marker's down, but your HbA1c might be still elevated. That has further ramifications. So we do see that. And unfortunately, as you get older, our elderly patients, we do see them sort of get worse over time. Yeah. Whether that be an aging thing, or that be a compound effect of the medications, it's hard to say. Could it be a perfect storm? Absolutely. So, yeah.
It's one of those things like, in our industry, no injury, as physios, no injury is the same, or no person's the same. That's the biggest thing. It's when someone comes to see us, we're not really like looking at the diagnosis too much, really. We're looking at, obviously it's important, but we're looking at the person and all the factors that plays into that person. So you're at your end, you're still looking at, right, all the what are the other factors, what other drugs are they taking, their blood tests and things like that. You are looking into that. It's not just like, they've come in for this script, here it is, so you know what I mean?
Yeah, I think, look, pharmacy falls in two spaces. Yes, there are, I don't want to badmouth anyone, but some pharmacies operate on that, come in the script, get out, see you later. I think our team prides ourselves on being a holistic in that sense. Mrs. Jones, how you going? How's this? What's this been? What's the doctor told you about this? And we try and ascertain where it fits in, if it's appropriate. We've had dialogue with some doctors going, hey, this may not be the best for Mrs. Jones, who's 85. She has a falls risk or whatever. Can we amend it? Sure. Most of the time it's, no, I want to stick with it. Let's go with it. But as long as we have the conversation, I think that is important. It's important to look at drug-drug interactions, but also drug-disease and drug-person interaction. No, like as you said, no one's the same. I might take a blood pressure medication, it sits at 120 on 80, cool, no problem. You might take it, it drops down to 80 on 90, and then, you got a car crash, God forbid. But, things like that. So it's important to have that conversation and realize that.
We're definitely, sorry, I was going to say, we're definitely in a society where, we're looking for quick action. And often, we see it all the time, but often it's like someone comes in and says, I have this, so I need to do this. And it's like, well, that may have worked for that person, but that completely different, situations. So do you find that people are constantly like, oh yeah, well, my doctor said this, so it must be this, or my friend is taking this, so I need it. It's going to help me. I'm going to get the same results. And then do you have to then try and...
Yeah, absolutely. So my biggest enemy is people talking to each other.
Yeah.
And Dr. Google as well.
Dr. Google, Instagram.
Everything's social media. TikTok. I saw this on TikTok. Hey, this has got to help me, right?
How often do you hear that?
All the time. I get hey, there's this new thing coming out from the States. Have you got it? I'm like, mate, I really haven't even. Yeah. I don't have time to look at TikTok, A, and B, I haven't even heard of it. So. Yeah, I do. That's my biggest two pet peeves. It's like, my friend's got this painkiller. Can I take it? I'm like, no, mate, you can't. Yeah. Or, I've got an ache and pain. Someone recommended me Voltaren. No, you're going to have kidney failure in a week if you keep doing it. So it is important, and it is a common thing, absolutely.
And in terms of I know that obviously last year, there was a big change in the way that pharmacy was dispensed and those kind of things, and that obviously had an impact on the bottom line of a lot of pharmacies, right? And I know when I've spoken to friends that are pharmacists, that doesn't just impact their bottom line and all that kind of stuff, but it impacts the service that they can then provide for that client. It wasn't just about dispensing the medicine, but they were then able to dedicate time to have, like you talked about, what are the drug implications, what are the drug disease implications. Whereas if the bottom line decreases, you don't have time to do that. The only way to make that up is to pump more prescriptions or sell more product, right? I know that obviously that part of that got processed through. There is talks about trying to reverse that. But what have you seen then in the service side of things? You know, I'm sure everyone's going to want to try and give the same level of service that they were before, but realistically you can't if you don't have the funding to do it. So how's that impacted your service?
You hit the nail on the head.
Yeah.
Say, for example, we saw Mrs. Jones every month because it's a 30-day fill of scripts. We've got a good regular check on her. But this, you know, the new double packs, we see them every 2 months. That's also reduces the amount of time they spend in the pharmacy. That's the amount of time they come to the shop.
Mm-hmm.
Sure, they might come in and get an odd thing here and there, but if we're seeing them less frequently, you have to make up for that somehow. So yes, it's a huge push now back to over-the-counter sales and over-the-counter counselling, supplements, whatever it may be. But it's moved on to that dramatically. So I think that's the intention. I don't know if it's the intention of the government, but it's to move away from a dispensing focus onto a primary healthcare focus, wound dressing, simple cuts, grazes.
Pharmacists to do that?
Yeah. So like a superficial scrape, for example, come in, get some saline, good dressing, off you go.
Who's going to do that?
Well, that's the thing. Is it up to us to do it? There's no remuneration. There's no Medicare card that we can swipe to account for that time in that sense. You know, you go to a doctor, bulk bill, bang, off they go. They get paid. They get the, you know, they might get a discount on the, you know, they get paid regardless. They might get a discount on the dressings that they use. Yeah. We still have
So the intention with that was to change the use of the pharmacist?
In a way, yes. I think, you know, the more focus on, you know, vaccinations, the primary healthcare space, you know, whether, you know, they're moving into there's a new prescribing trial that's come out. So oral contraceptive trials, that's sort of slowly taken off. Acute, minor, like simple antibiotic treatment for UTIs. Dermatology is a new space as well. So I think they're trying to utilize pharmacists in between doctors, in between emergency care. How can we alleviate that pressure at that level? And let's move away from the dispensing, move away from behind the counter.
But who's pushing that? Because clearly if the AMA doesn't approve that, then nothing gets passed, right? Yeah. So is it the AMA that don't want to do this anymore? But that doesn't make sense.
No, I think, well, look, it was met with a lot of backlash from the AMA. The pharmacy guild has sort of put a big push, like, hey, we're more than just dispensing robots. We actually have some skills. We have some knowledge. We had to do some sort of basic medical training to get to where we are. Let's utilize that. I think because dispensing fees are coming down, price disclosure and all that sort of big business side of things, profit margins are getting really tight. So we have to make money elsewhere. So chains like Terry White, they'll offer huge sort of health and well-being services. For example, they'll do like a weight loss clinic, a smoking cessation clinic. I don't know how they price it. I don't know how they make up their bottom margin, but I know that there's a big push for them to.
But wasn't that some of that was subsidized by the fact that there was regular, you know, from my understanding, obviously I'm not a pharmacist, but from my understanding was the fact that they changed the time frame of scripts, that there was a loss of funding for those kind of extra services. Those extra services came out of the top line. And if the services were coming in more regularly, you could pay for it. If the services come in less regularly, then because I think they cut the costs too, right? So, you know, I don't know the math behind it, but if you're getting X amount every 4 weeks, you're only getting 1.5x every 8 weeks, right?
Correct,
so you're losing a quarter of your revenue.
Yeah,
right?
Absolutely.
So if that's the case, then you can't provide those services. How are Terry White doing it? Like, are they trying to get rid of the smaller guys? Like, how does that work?
I'm not sure, but you hit like spot on with the funding. Yeah, it was everyone thought, or general public sort of perception was, I'm getting 2x, you must be getting 2x remuneration. No, it's actually 1.25, 1.5, whatever it is, whatever it works out to be. So I think pharmacies had to find a way to make money, to stay viable. Yeah, that's sort of a pharmacy guild. They have a community agreement at a government level, and they discuss funding and where money gets funneled to and whatnot. So not sure how different franchises operate and how different franchisees choose to operate, but yeah, they had to not scramble, but find a way to make up that difference there. And, you know.
Okay. Interesting. And then obviously coming back to how that impacts the service of things, right? You know, you talked about the way in which, you know, if there is you know, a lot of people on mental health medications, a lot of people on, you know, whatever chronic disease that it might be, especially with cardiovascular disease. I'm sure that's huge. It's like #1 killer in Australia, right? So if there's a change in the way that it gets prescribed, if there's a change in, you know, the particular medication that all of a sudden doctors start choosing to do, how does that impact your business? How does that impact your ability to provide a level of service?
I think we have to adapt pretty quickly. We'd have to learn about the drug pretty quickly. Might have to learn about the side effect profile because more people are taking it. You might get more feedback in that sense. So I think you'd have to just educate quickly and just understand, okay, where does it fit in the prescribing guidelines? Or, you know, something that might have been third line is now first line, and vice versa. So you think, shit, what's happened, and what is the logic behind that? Why, you know, from a physiology perspective, how does that make sense?
Yeah.
You know, so.
Okay. So it sounds like you guys are kind of stuck in the middle,
Yeah.
right? You're stuck in the middle of seeing, you know, the effects that certain drugs have on the individual, but there's not much you can do about it because you're pretty much fulfilling a script, right? Yeah. What areas do you kind of see? And then I guess that has an impact as well. It's like if you don't fulfill those scripts, you guys don't make the money, right?
Exactly.
So then where do you see the missing piece here? Because like, obviously pharmacists aren't doctors, physios aren't doctors. Like we have to stick to our lane somewhat,
Of course,
right?
yeah.
But there's clearly a breakdown in the overall health system, right? In the way that individuals get treated. Like Harry said, you know, there's a lot of boxing people in, but not treating the individuals. So is that where the breakdown is? And, you know, doctors can't necessarily do that. They don't have the time. Pharmacists can't do that. You're not allowed to.
Yeah.
So how? What's the breakdown here?
Excellent question. That's an excellent question.
Yeah.
Should be health minister, mate.
No, I won't get paid enough.
I think there is a disconnecting. Like, I wish there was a bit more of a streamlined communication. I wish there was, you know, I could write an email to GP saying, "Hey, Mrs. Jones not doing good on this cardio drug. How can we proceed?" You know, more often than not, I hate saying that, but go back and see your doctor. Go back and discuss it with your doctor. Appointment might not be for 3-4 weeks. Doctor's on away. What the hell do I do now? You know, most
Still
doctors
living.
are. Yeah, exactly.
They're still living like.
Yeah, exactly.
So, and you're quite like accessible for those people.
Absolutely.
So they can and usually like I'm sure they're local to the pharmacy, so they'll just pop in. I know we do that. If we can't get to the doctor, I'll just run up to the pharmacy. Yeah. So do you find like that? But then you're sort of like hamstrung on how much you can actually do.
Correct. We have our limitations. We have to stick within our lane. There is only X amount we can do. We'll try and do. I mean, you guys do. You try and do as best as you can within your limits, but
yeah,
there is.
Is that based on knowledge or bureaucracy?
Yeah, I was going to say
red tape based, basically.
Yeah.
I think the regulations are so tight for a reason. Don't get me wrong. I agree with it, but that also caps us at a certain point. You know, you look at different models overseas. For example, Canada, I think, has moved into a pharmacist prescribing space, which may bridge that gap. You know, I'm taking Crestor 20 milligrams for my cholesterol. I'm getting horrible side effects. My bloods are okay. Can I drop down to 10? I think the pharmacist, from what a basic understanding, pharmacists may be able to sort of de-prescribe in that sense and go, okay, let's trial 10. Let's do your bloods in 3 months. Let's see how you go. Cool, everyone's happy and everyone's informed in that sense.
And quick.
But that's just common sense, right?
Yeah.
Like we're not saying to someone who's on whatever that medication is to put them on something completely different.
No, absolutely.
And or change the medication or
like take them off something and put them on something else.
Yeah, like so it's just that there's not allowed. There's no area for common sense.
There's no room to move, and it's a shame to see because you look at different regions and how they operate, and you're like, yeah. Logic dictates you're getting side effects at 20. Let's drop it down to 10 to see how you feel. X, Y, whatever it may be. That would be nice to see here, but I think I don't know if it's the industry or people may take it too far. Like you said, someone might just completely chop and change a medication without anyone's knowledge. Yeah, they end up in hospital. Yeah. Who's done this? Hey, Mick down of the pharmacist's done this. What's the ramifications for me? Is it? Am I liable? Of course I am because I've done that. But where does it?
But here's the issue I have, right? Is that that's easy to point the blame on the pharmacist if they've done that. But if the doctor did that, no one goes after the doctor. So I get that there's a different level of training, and doctors do have a completely set of different skills to what that is. But then if there is an area, if there's a skill set and a knowledge that someone can help an individual there, again, with the right information, with the right, what's the word I'm looking for, with the right reasoning to do it, right? Then isn't that benefiting the individual?
Absolutely.
Okay.
So the healthcare system wins. The person wins at the end of the day. There's less stress on everyone. Everyone's sort of cohesive and works in the space together. So, yeah, that'd be an ideal world.
Yeah.
Unfortunately, I don't see it happening anytime soon in Australia, but it'd be nice. It's a nice way to operate. I think maybe not just a pharmacist off the bat. You might have to do an advanced diploma or something further to bridge that knowledge gap between being an MD and a pharmacist. By all means, go for it. I'm happy to endorse that. So yeah, it might be a way to accommodate that.
Because you must really sometimes like bite your tongue, because I have a real problem that if an elderly client of mine or my grandmother was not feeling well, she'd been on a new drug, and when she'd been on it for a week or whatever, she got it from a doctor, and then she went to the pharmacist, and then you knew that like, oh, you should probably be like, maybe we should just drop down this dose or something as simple as that, and then you're sort of like biting your tongue and go, look, just going back and see the doctor. And then she has to wait to try and get a doctor. She can't get there because it's further. She has to organize a lift and whatever. All the time, she's like not doing well. And you sort of, as a pharmacist, not putting on you, but like, then you know that's an issue, but you can't do anything about it. Yeah. Do you find that sometimes you're just like, look, I'm not asking you to go against what you're meant to be doing, but do you find it very, very difficult at some of those points?
I agree.
Go to see your doctor like ASAP, today? Or
that's what I try and that's what I try and enforce. I'm like, this has to be done now, kind of thing. She goes, I feel, for example, your grandma, I feel dizzy, I feel unsteady on my feet. What's changed lately? This logic dictates, that's what's sort of affecting it, or it might have been the straw that broke the camel's back. Everything might have been okay. Add this one on, and there's too much on the body. Then what do you do? It'd be nice to say, stop taking this, but And
then sometimes, do you feel like then a quicker fix is to, try this supplement or add something else that you can recommend?
Yes and no. I think there is limitations. If someone's for example experiencing myopathy, muscle soreness, statin, number one side effect. First thing we tell people, more than likely you get leg cramps. Cool. How do we mitigate that? Let's add some magnesium. Let's add some coenzyme Q10. It will help. And in that sense, they might come back to you in a month and go, shit, thanks for that. No one's mentioned that. No one bothered to tell me about that.
But in that case, right, so here's an issue that I have with that, right? If someone's getting a side effect, it's clear that, okay, they might be benefiting from that medication, but it's clear that medication is having an impact on their body, right? So is anyone looking at, instead of, and we kind of touched on it before, but if we're giving a medication to fix X marker, it's usually from a blood test, it's usually from some sort of symptom that the client's receiving, right? Are we looking at anything else other than just pharmacological interaction?
I feel no. I feel like it is, let's go with this drug, go for it, as opposed to taking a holistic approach. Yeah. If someone's, blood sugar is elevated, let's look at your diet. What's that like? Yeah. If you've got a chronic inflammation, could it be a dietary factor? Could it be exposure to something? Could it be X, Y, Z, Yeah. I think there is more of a holistic approach we need to look at. I agree. That's my sort of sentiment, as opposed to let's just write a script and be done with it. I think, as you said, it's just a box approach. I think everyone's on a spectrum somewhere.
And now, like, I know that this is going to be touchy because you guys can make a shitload of money out of this, but like even something like Ozempic being,
I was wondering when that was going to come up.
Well, like I just thought about it because you just talked about going for exercise and things like that. But like that's a whole nother one. Like it's obviously something that works, right? And there's results that are like through the roof in terms of how that works. But like at the same time, doctors are prescribing this as a fix for something that's completely like there's a lot of other fixes for. So like, I just use that as an example, right? But that could be happening for everything. That could be happening for mental health. That could be happening for cardiovascular disease. Like anything any of the diseases that are affecting that individual. Are doctors, and I don't know because it's not something that I can make direct comment on, but are doctors just going straight for prescription, and then you're sitting there going, "I'll fill this prescription. You're going to get paid otherwise, right?"
Exactly.
But as someone we're in the healthcare industry, right? Like, it's a chain of money, and I get that. Doctors don't get paid to go give you exercise advice, right? The client won't go there because it's not a quick fix, right? But at the same time, like, are we just? Is it a cash reason that we're doing it? The doctor won't get paid unless he gives a prescription. You guys got to fill the prescription because otherwise they'll go somewhere else.
Yep.
But no one's actually looking after that individual. And then we're giving them magnesium because they've got leg cramps.
Exactly. So
which
it's
again,
a vicious cycle.
It's fine. I get that because you're dealing with what you get given.
Yep.
But maybe that person shouldn't be given that medication to begin with.
Yeah.
Because they just need to go for a walk.
Yeah, exactly. So it's a fine line. I think in Australia we like the quick band-aid approach. I think we tell people a lot of things. We'll see kids coming in with a viral cough, for example. You just have to ride the wave. It's frustrating. Yes, I agree. You're having sleepless nights. Everyone's like, I went to the doctor. He didn't give me anything. Wasted my money. I'm like, I think that's also a mentality that we have in this country that we just like a quick. I'm feeling down. Give me something quick. My kid's got a cough. Give me antibiotics. So it is. And we're trying to balance being responsible in that respect. We've got this huge antibiotic crisis that's happening at the moment.
What's it?
Antimicrobial resistance. So common antibiotics that worked for a cut, graze, chest infection no longer are effective because all these super bugs are sort of coming out because of misprescribing.
Okay, so we've become immune to the
so basically the bugs that are causing these ailments are smarter. They've evolved to beat beat the drugs that we have at the moment. So that there might be.
But okay, I didn't know this. This is craziness.
Yeah. So when I
the
understand
bugs are smarter than us.
Yeah, exactly. They evolve at a rapid rate.
That's a fucking problem.
That is, and it's not just ramifications for a cut, graze, but think about someone that's going into surgery, for example.
Yeah.
And they've got to have prophylactic antibiotics, but they have an open heart surgery. They catch an infection. They can't treat it. That's it. It's kind of a scary thing. It's not just
So don't have antibiotics.
Yeah. Well, limit your use of antibiotics or take them correctly.
Sorry, just to understand this.
What's the taking correctly part then?
So if someone says take it for 5 days,
most
people after day 3 will be like, I'm better, I won't take it.
Yeah.
That leaves some sort of residual colony or whatever, left over.
We see this.
And then that has ramifications. It may come back and you take the same course again. It doesn't work. Why?
Right.
Because there's resistance to it.
Okay.
So,
but even that initial dose isn't gold standard anymore.
May not be. I think for
So let me understand this. So when I've got an infection, right?
Yep.
That is obviously antibodies and it's a bug. Let's just call it a bug of some sort, right? The current if I take too many antibiotics or if I didn't follow it through, the antibodies or the antibodies of the bug have worked out that it can beat this antibiotic, right?
In a nutshell, in a rough, crude way, essentially,
But does it know that before? So if I get an infection right now, the bug that I currently have for that infection smarter than the antibiotics?
It depends. So if you look at things like Staph aureus and in things in the hospital, they're getting quite intelligent, for lack of a better word. So you have to throw everything at it. You have to throw harder antibiotics at it. But then if you use your last line of defense and they're beating that, then what the fuck do you do then? So then
holy shit. The bugs are smarter than humans. I love that.
Can be.
No, you said they were.
No, throw me under the bus.
Okay, that's a problem. Anyway, let's we sidetrack.
Exactly.
There's a crisis coming on here.
But we're honest, in all seriousness though, we joke about like for the little things, but like you say, in hospitals and someone's already elderly, all those things, right? Elderly, probably low immune system, all the rest of it, and then going for like open heart surgery, and then we're still doing these procedures and everything because they need it to survive. But if they get an infection, we're in dire straits.
Pretty much, yeah. It's a scary thought. So they're in the hospital pharmacy space. They are trying to actively work on this. So it's not doomsday, guys. They have a antimicrobial team. They'll look at, doc might chart this and they go,
it's not going to work.
Not going to work, or it's inappropriate, or let's tailor it to a better way. So it comes to that thing we were talking about, bridging that gap. Someone making an informed decision, common sense dictates. So it does operate in that space. I'm probably coming from a community pharmacy. That's where it's frustrating. But I think in a hospital setting, in that sort of team,
of course.
It works. It works. It works well.
Okay.
Right.
So just coming back to before we started freaking out about
superbugs.
But I guess for me, right, my concern is what's happening at an individual level, right? And we can sit here and talk about, the way doctors prescribe, the way pharmacists are seeing things. At the end of the day, like it's the system that we're in. Most countries are the same. Some doctors are exceptional. Some doctors are lazy. Like it's just the way that anything is. Some physios are exceptional. Some physios are lazy, right? That's in any open market, right? You're gonna have that. He's one of the lazy ones.
You said it.
I can't record that. I don't know. That's all fingers pointing out.
But what I'm trying to say is that's normal in an open market.
Yeah, of course.
Right? But what I kind of understand is that at the end of the day, people make decisions based on money, right?
Yeah, ultimately.
And the decisions based on money, whether it's the client, decisions based on money, whether it's the business owner or the doctor, or whatever that is, where do you see that the problem right now in terms of, like, we talked about this before, if there's an alternative to mental health, you said like 1 in 3 prescriptions you're seeing right now are mental health, right? It's a third of your revenue lost. If
I start telling people go for a walk in place.
The stats last pod.
14%
of Australians taking some sort of antidepressant.
Yeah, no, it was higher, wasn't it?
No,
it was almost 20%. Either way, it's like 1 in 5.
guys.
1 in 5.
1 in 4, 1 in 5. Let's say,
Yeah.
roughly. It's like you said.
Yeah.
If I tell someone, hey, let's not do this, let's not use this script, let's try alternative methods, or let's try something else.
Yeah.
It's going to affect my bottom line too.
Yeah.
So it's also up to the patient too. I know some patients come in, they're a bit hesitant to start, or they go, I've read up on this online and I'm shit scared of the side effects. Or I might have a complete 180. I might go worse. I might not necessarily get better. What do I do then? What can I do in place? There's certain things you might refer to, psychotherapy or things like that, whatever it may be. Could be going for a walk, journaling, something simple that we can offer. Yes, it's free. Does it give me any money? No, but it may.
If you sold the journal, it would.
Hey, I should tell my boss. Hey, start selling journals. Possibly he might not. He might
send
phone
them
up
to
on
us.
that.
We'll give you a kick. No,
That's after. That's after. But that's after.
Yeah, I heard ya.
We'll bring out the contract later. It may. I may not see them again, or I could have a lifelong
100%.
patience. It's hard to gauge.
Yeah.
It's 50. I think it's a gamble that you do have to take.
Okay.
Unfortunately.
Yeah, but it sounds like you're trying to take the sort of service part into it and like being holistic. You've got time for that?
Yes and no. The days that I do, I love to help people. Some days I'm just inundated.
Because you said it's like a bit of your driver. You said at the start.
Yeah.
You like to help people. You like hearing the stories when they come back that you've helped them, whatever.
Absolutely. Time is our biggest enemy. I think in any healthcare profession, you want to remedy this, but you've got 45 minutes or the patient's got to go, or whatever it may be. I find people at our pharmacy are just on the go. Sometimes you might get the odd couple, newborn or young child, they want to listen to what you have to say. Love it, great, but it is rare to find. So.
Okay.
And because we're talking about like the problem, I guess or the gap in the industry between doctors and pharmacy, like do you think there's like a lack of trust in pharmacists to provide that service that you're doing? Because like if other people other pharmacies are just filling scripts and not actually taking the time to talk to them because of, that's the money going out, and that's what that's all they're focused on, then are we putting heaps of red tape around because it's like, okay, well, we got to be careful what are they recommending, or we don't trust them.
But that's a good question. Just to back onto the back of that, last year when obviously all that stuff was happening in the pharmacy industry, there was a big divide in people going, "Why are you doing this to pharmacists?" And then a lot of people going, "Yeah, fuck them," like, you know.
Yeah, they make enough.
But it's like,
so where's that trust breakdown?
Because if you could, like, if you took your Medicare card to see the pharmacist and said, like, okay, now pharmacist is going to spend 10, 15 minutes with me or whatever it is, and they're going to, like, adjust it, I get the answer right now, and I get the better assessment as opposed to just, you know, here it is and moving on, even though it might not be the right equation for my body at the moment, and they swipe their card, then obviously then that will then, if there was a code, if there was some sort of rebate to the pharmacist, but at the moment they're not encouraged, they're not incentivized to do it.
Well, I'll let you answer that, but I think that the issue there is that I don't think the government want to fund that. Like when you swipe your Medicare fund, someone's going to pay for that.
Yeah, I'm saying, is that because of the lack of trust that there aren't enough mix around doing like the whole service and the holistic part?
Again, I won't answer that for you. I'll let you answer
possibly.
That, but I think there's more than that.
You know, may very well be. You know, there is, I think people are shutting down that service side because there is no incentive to, and that has then a negative effect on people. You know, I went to that pharmacy down the road, they didn't give two shits about me. I come here, one of our staff has a chat with them, they're like, why the disparity? Yeah. So I think it is a choice, but there's also a lack of incentive, which is driving that choice too.
Yeah, okay.
But because from my end, right, if it's Medicare backed, right, that funds need to come from somewhere, and I think that the whole reason that they were cutting from 4 to 8 weeks was because of the cost of dispersing medicine to begin with. So at the end of the day, it's a cost problem, right? You've got
more likely to go the other way.
Yeah, because you've got a pressure from both sides. You've got a pressure from, big pharma pushing shitloads of medications out there because that's how they make it. You've got a pressure from the government who are trying to provide socialist healthcare but can't afford to do it. So who's going to pay for it? Unless you as an individual start paying for that shit, which then they may not because they don't see the value in it.
That same
who's
person
going to
has
pay
to
for
go
it?
back to the doctor anyway and pay there with that same Medicare card.
Yeah, but then who likes that? The doctors like that.
Yeah.
Exactly, and the doctors are massive. AMA is huge. So they're always going to... Everyone's going to, rally for what works for them. The doctors are going to want patients to come see them. That's why also, we're in a GP-centric model. Everything, even to go see a specialist, you've got to go see a GP to get a referral to see a specialist. Even though the GP may not have any fucking idea what's going on.
Yeah.
You still need to go to get the referral from
even
the
us,
GP.
we see that as a roadblock.
Yeah.
We're
not primary.
But even, I understand. But like, even if someone comes to see us and we're like, we rarely, in sort of how we operate, we don't really send people for scans that often anymore. But to get someone to have a scan, it's if they're going to accept our referral, fantastic. If they do, then they charge them more. I know this is a different sector, but like, we're really just encouraged to send them back to their doctor to then get a referral to go and see the specialist that we want them to go and see, or for the scan. So are we just, and then the doctor's overloaded anyway. So
the doctors are overloaded, of course.
Yeah.
But they want to be overloaded.
Then I don't know the answer, but good luck, Nick, mate. I need more of you, mate. Maybe the training needs to be better.
Possibly.
Do they do? I mean, at university, was there a lot of like the service side of it?
I was in our sort of I did a master's degree at UTS, so there's a heavy focus on that. There's a focus on. We do a whole semester on
patient-centered and stuff.
Patient-centered, Mrs. Jones we do a lot of role plays. Mrs. Jones comes in with her daughter, XYZ.
Yeah.
Bob comes in with Grays. What do you do? So there is starting to move towards that, and I agree with that. I think it's important not just to be book literate, but also be compassionate and also understand what a person needs at the end of the day. You might have XYZ recommendations, but if you can't talk to them or you can't counsel them effectively, then it all just goes to shit in the end.
And it doesn't have to, like we said before, it doesn't have to be big changes that the pharmacist can consult and make. Even if it was just the small ones, like you were saying about the 20 milligrams to the 10 milligrams, that would be a big help, wouldn't it? Yeah.
I think that would take a load off the GP-centric model. There might be that bridge there. That might, may help. I don't know. It may not. It may cause more problems in the future, but it's at least worth trying. Or at least having that discussion at a government level, going, okay, how can we better? It's a decent workforce. Yeah. We're not massive. We're not GP specialist numbers, but decent number of us in the country, especially Sydney Metro. There's
fucking heaps of pharmacists.
In our area, there's 8 or 9 pharmacies in our cross section. Just in where we work. Pharmacists
are bad as physios. Physios in every corner.
No, there's like three next to you guys up there. It's incredible. Yeah. And then everyone's got 7. Every pharmacy or every physio's got 7, 8 people working in there. Then shit, So there is a hugely underutilized workforce. So can we have like a specialist in that field? Nursing has that. Nursing has nursing prescribing now, and they have a certain chain of command and further advanced things. So I agree with that by all means. You see that in the outpatient sort of setting, a lot more streamlined. People go in, I need my insulin dose adjusted. Cool, let's look at your numbers. Nurse sees them, runs it by the whoever's the attending. Bang on, let's go, guys.
So a nurse can do that.
So I think it's a nurse practitioner from my understanding.
Okay, so there is extra study.
There is extra study involved. Okay. It's not just off the bat.
Yeah.
But I agree with that. I think we should have maybe a more advanced or a higher study level, whether it be a physio, whether it be a chiro, whether it be a pharmacist, a bit more advanced specialist, if you will. Yeah. And then
I've been in a hospital setting where the nurse is telling the doctor what to do with his client, like his patient. So I kind of understand that. And again, I think it comes back down to, in a hospital setting, maybe it is more of a team environment because you've got the nurses and the doctors, and the doctors understand that the nurses are spending more time with them than the doctor can. Yeah. But in a private setting, out in the rest of the world, doctors maybe don't know who you are.
Exactly.
As a pharmacist.
I'm just Joe Blow. We're very fortunate. We work very close with the medical centre around us. Yeah. But a lot of people don't have that luxury, I don't know, it might just be Joe Blow, or I might get a script from Russell Lee or Blacktown. I'm never going to see this patient again, I'm not their local. But I think it's important for me, not just business-wise, but also continuity of care, that you have a local that you go to and everyone's, I understand this patient's profile, or the team does holistically. So, I can't coerce anyone to go anywhere, everyone has freedom of choice. It's consumer law at the end of the day too, so yeah.
Okay. And just coming back to obviously we talked a little bit about when you're seeing effects of medications on individuals, or whether or not there is other ways to deal with that particular problem, right? Do you think as an industry, as the health industry across the board, it doesn't really matter whether it's pharmacy, doctors, physios, it is a big push, and I know this is like a go-to term, but big pharma do have a big impact on the way in which we treat certain conditions, right? And there's a reason that they got to that point, right? Yeah. There's lots of money behind it, there's lots of advertising, there's the results behind it, there's all these different avenues we could go down, right? But then when we are looking for alternatives, and whether it's supplements or whatever it could be that is an alternative to someone, where do you think the pressure comes from? Where do you think, I guess, the why is it in the current situation that we have?
That everyone's sort of just pill popping and happy in that sense. I think it's lack of education, or I think the conversations had, what else can we do? Some people are hesitant.
Their own education is coming from big pharma, right?
Exactly, and doctors, and they get educated by XYZ. So it is a chain of information. If I print out a product information leaflet and give it to someone, it's like 12, 13 pages. You read it, you're like, what do half these words mean? And this scares the shit out of me, so I'm not going to take it, or you know what? Fuck it, hedge my bets and just take it anyway, So it's hard to disseminate medical information that comes down, break it down into lay language, and then help. Look, it should be joint decision making at the end of the day. This is the side effects, Mrs. Jones. Are you happy to proceed? Are you willing? This will happen. This may or may not happen. I think we have to be very careful in the language we use.
For someone that originally looked into going down the making of those kind of things, why do we accept side effects?
Very good point. Very good question. I think, some things are... Jeez, that's something. Yeah, very good question.
Sorry.
That's all right,
I don't
mate.
mean to stump you,
What
but
side
like,
effects have you got? I don't know. A bit of a twitch.
Anger.
Flushed face, twitching.
Anger. I'm always angry.
Angry.
no, it's not that. But
We shouldn't accept side effects, really. Ideally, the ideal medication would be we take it, everything's better, everything's hunky-dory, and then we move on with our lives. But I think anything foreign in our body is going to have a side effect, whether it be a supplement, whether it be, a natural hormone that we take, for example. Oh, not natural hormones, like an additive to rebalance. It's always going to have something. It's exogenous. It's foreign to us. It's going to have an effect somewhere, whether it be liver impact, nausea, vomiting. Number one for basically everything that you take is, nausea, vomiting. Everything's not all. I think it's not all drugs are poisons, but all. There's a saying in pharmacy that we learned that.
Learnt it well.
Yeah, shows you how much I paid attention at uni. But
maybe because
that class.
Possibly, but no. I think everything is. It's either dose related. It's dose related, but also we shouldn't accept it either. But it comes down to it's foreign at the end of the day to our body.
Yeah.
So
It's also because it's the unknown. It's like, it may cause this, may not.
that's the thing. Like,
it might to you, it might not to you.
that's what everyone's different. As we touched on at the beginning, everyone's different. I might take something, I might feel like Superman, I'm good. You take it, you start withering down because you have, your muscle breakdown, which is a listed side effect. So where do you draw the line? Where do you...
But is that unknown quite scary in a way that we're taking, if we are in this sort of culture where it's like, okay, I need something quick and I'll take whatever I need to take.
It's scary. And then people come in and go, well, why don't you tell me about it? I was like, well, you didn't
didn't
bother
read the
listening
12
to me.
pages?
Yeah, you didn't read the 12 pages, or I warned you and
You're
you
sick
still
and
chose,
desperate.
I can't force someone to take a tablet.
Yeah.
Yes or no, either way.
It's really interesting because if I can't remember what you called it, but if there's a document on each drug that's 12 pages long, normally when it's that long, my lawyer has to look at it.
Exactly,
So
and then highlight the key points and give you a summary, right?
Exactly.
Yeah, it is. It's published information. Every drug company has to do that for the medication, so it is publicly listed. But who's got the time to go and look up XYZ info on this?
Yeah.
It comes down to us because people expect us to do it as an information provider.
Yeah.
It should be part of your counselling process. What you learn at uni, you print this out, highlight the main points, and give it to them.
So that's supposed to happen.
Ideally. But does it happen
In the pharmacy?
Yeah. Who's got the time to do that, right?
No, I'm not questioning
No,
that.
no,
but but why isn't the doctor doing that? They want to prescribe it.
Very good question. So, there should be an education level at that point.
Yeah.
I'm not too sure what happens. I'm not afraid to, doctors consults. I'm not, what their decision making is.
Yeah.
But,
but as a consumer, I don't think I've ever been, and I'm not having to go my doctor or any other
but
doctor, but I've never been in a doctor's consultation and they said, taking this, by the way, here's the printout, here's the things to be wary of. Do you understand these kind of things?
Yeah.
Like if the doctor says take X, I'm taking it.
Exactly. You just sort of trust. There's a blind trust.
Yeah.
In a way, Yeah, where do you point the finger, right?
I'm not pointing the finger.
I'm just saying, where do you delegate that responsibility?
Yeah.
Is it me as the medicines expert? Is it up to me to educate the person? But then who's got the time, and who's really interested? Just give them my script and go. I've got X, Y, Z. It's just a very...
TikTok doesn't have these documents either. When you see on TikTok,
TikTok's not going to have
before and after. They feel better
from TikTok.
Surely you see it. We said it before. Don't we?
I know we said it before.
Yeah,
but
this supplement's
you're not
supposed to
getting
be
that information.
this is supposed to make me feel like the Hulk. Do you have it in stock, and what do you know about it? Mate, I really don't know.
Yeah.
So yeah.
I guess following on to that, right? Obviously, there's a lot of talk on Instagram, TikTok, all those kind of things on, all these different health advice, right? And there's a big push on these platforms around natural remedies and those kind of things, right? And I guess as a pharmacist, the only real natural side of it for you is supplements and things like that. What do you what's the trends you're kind of seeing there? Obviously, people come in and going, do you have X and Y? Because I saw it on TikTok. But we just talked about the impacts that pharmacological intervention can have.
Yeah.
Are supplements strong enough to replace I'm not saying it needs to replace it, but what's the point of a supplement if it's not to replace pharmacological intervention, right?
Yeah, I think we need to come back to the start. It's a supplement. It's not going to be cure all everything, right? So yes, it may be a co-prescribing, or will this make you feel better? Sure, maybe, yeah. Is it going to work for everyone? Maybe not. It's hard to say.
Okay.
But in terms of trends, melatonin's huge. Sleep is space.
People are taking melatonin?
Yeah, people take it.
That's a supplement? It's not a...
That's a TikTok trend.
That's a TikTok
sure,
trend,
man.
yeah. So I think, in Australia, they only...
So you look tanner.
Yeah, exactly. That's something else, mate.
Wait, is that what you do?
Why does it look like?
Oh,
no,
right.
I'm just getting some sun, mate.
So come back.
Yeah,
come back.
so-
People are taking melatonin.
People are taking melatonin, yeah. So
To do what?
Sleep better. Better quality sleep.
I thought it was literally to tan.
No, that's melatonin.
Oh, it's different. Oh.
Melanin. That's melanin.
Melanin.
No, melatonin.
What's melatonin?
Sorry,
Melatonin is our natural sleep
Scrub up
hormone.
on my melons.
Yeah.
Oh, okay.
Yeah, so
Wait, so it's
cica-
a hormone.
Yeah, natural hormone that the body produces through the
Right.
circadian rhythm
Yeah.
makes you sleep, deep sleep, quality sleep. So if your levels are low, everyone's having disturbed sleep. What's
Okay.
disturbing those levels? Blue screen,
Stress.
Okay,
anxiety.
now
So
I'm with you.
Yeah, but
So-
don't worry about the blue screens or stress. Just take the...
just take this.
Take the
let's
melons.
let's band-aid this. Let's take this and other things. Ziziphus, passion flower, all these sort of weird and wonderful herbs that have been around probably for thousands of years. The Incas probably took it. God knows.
Yeah.
A lot of these are getting produced now, mass produced, and people are swearing by it. They go, mate, this is the best thing I've taken.
Okay.
It's changed my life. It's like, well, is it a band-aid approach? Because you're sort of semi-drugging yourself up because you're having heavy sedatives
Yeah.
in a natural form. Are you fixing the root cause? That's another question too. So it's a
Yeah.
two-pronged approach.
Well, we're saying that with a natural supplement. Why are we saying that with pharmacology?
Oi!
It's full of them today,
I
isn't
know.
it?
Just go
No,
around.
legit question.
No, like I'm not
No,
pro. I'm not pro natural
anything. No,
supplements,
exactly.
right?
No, yeah.
Just asking them.
Just
I'm
answer
just
the
asking
question.
right?
Yeah. I think, if you look at, say, for example, sleeping agents and hypnotics, that's what the drug class is called, people tend to steer away from them because they have these nasty, nasty effects. They're sleepwalking. Ironically, insomnia is a side effect of a sleeping tablet.
Seriously?
Yeah. It's,
Yeah. Take this, but
take
you
this,
still
but
stay
you
awake.
may stay awake. Shit, what's the point in taking it, right?
Yeah.
So people are looking to these
Well, I'm already
alternatives.
staying awake anyway. Might as well take it.
To try and seriously?
Yeah.
Okay. Sorry.
Yeah,
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 go,
that's
go.
all right.
on,
That's
go
all
on.
right.
Yeah.
And then, so I think people are looking to natural alternatives, going, "What else
Yeah.
can I try? I don't want to go down this road. What else is out there?"
Yeah, but see, here's my issue, right? Supplements, and again, I'm not pro natural supplements, but supplements get attacked way more than pharmacology gets attacked.
Yeah.
Right, and we can sit there and say that they don't work. We can sit there and say that, I think it says on the label that these may work or this may promote this or this kind of thing. And there's obviously other reasons for that because they can't say that the natural supplement does work, right? There's obviously legalities around that. But why is it that we'll easily attack a supplement, but we won't give it the same treatment?
I think it's an implicit trust for the pharmacological. Like someone's researched this, someone's backed it, a doctor's endorsed it, a pharmacist has dispensed it. Surely it must be okay.
Yeah.
Whereas if I grab something off the shelf,
But you said surely.
what do you mean?
You said surely it must be okay.
Well,
So it's not. It doesn't mean that it is.
I mean, there's an implicit trust throughout the chain, right?
Yeah.
Yeah.
So I mean, like I said, I might dispense a sleeping tablet for you. You come back to me 3 days later, mate. This hasn't worked for me.
Yeah.
This is rubbish. Then who's at fault?
Yeah.
Then so I think there's an initial implicit trust
I
that it
want a
will work.
refund.
I want to give back my money.
Have you ever got that?
Yeah, all the time.
Really?
All the time.
Finish the whole box. and
Yeah,
get another refund?
there's a quarter of a foil in there. Like this tablet didn't work for me. I'm like,
You can't.
it's like, okay, you can't return medicines, A, and B, I can't give you back your money for a product that
So you finished.
you finished.
Yeah.
Surely, like you've gone through the whole box.
Oh,
Difference
I
if you
still
took
get
one
that.
tablet, I've passed out. Then by all means, yeah, sure, we'll organise and we'll change things over for you, sure.
Yeah.
But if you've gone through a whole
Yeah.
box of something and said, mate, this is rubbish, then
I want compensation.
yeah, why'd you bother coming back to me for? It's an interesting space, yeah.
Whoa, that would suck.
That would.
Because then you
suck.
would have to pivot and go, okay, well, obviously this didn't work for you for this and this reason. I didn't know about, but then let's go.
Let's try
down.
something
Let's
else.
try something else, and then like, no.
No, I don't try. That trust is broken immediately.
Yeah.
That trust is automatically off the bat, just gone.
That would be hard.
Just come back to this implicit trust. No, because I think for me that
Calm down,
that
mate.
part of it is what's frustrating, right? Because then, like, I've never thought of it like this. But if I'm trusting my doctor, like I said, if the doctor says take this, no one prints it out, I believe the doctor. The doctor's getting his information or her information from a pharmaceutical rep, who gets their information from whatever the drug company teaches them, from the printout sheet that was done theoretically by a chemist, but that can be completely tainted along the whole line.
Possibly.
The chemist could taint the results. The drug company doesn't give a fuck because they're going to make their money back.
anyway, yeah.
The rep then goes, well, I only get paid if this drug gets sold.
Yeah.
And the doctor doesn't know any better because that's what they've been told in the whole chain.
Yeah. So it's a very interesting space. I've got a friend that works in this. He reviews articles and he reviews publications in order to promote. He doesn't just go in there and say, hey, our drug's 59% better. He actually comes in with stats, and he works in the immunology and virology space, which is fascinating.
Send him in.
I will. Actually, I might recommend him in. He's a top bloke. He's a really good guy. He's used to be a pharmacist in the community, moved on to the drug space. So I might refer him in so you can get the other side to it. But I think there is that, like, okay, the results are here, but who's analyzing it? Who's, I could say it's 59% better relative to what? Is it a 0.1 to 0.5% increase or decrease or whatever it may be?
Yeah.
Then I can say whatever sort of stats I want because it's sort of skewed in that way. So, yeah.
So that does happen.
It can, it does happen. We had a subject at uni where we focused on this, right?
Yeah.
We looked at different articles and other results true to the statement or the objective at the beginning.
Yeah.
I don't want to say 9 times out of 10, but more often than not, it's like, there's conflicting evidence here.
Yeah.
And where does the truth lie?
That's intense.
Yeah.
So yeah, okay. But let's take your mate for instance, right? Obviously, he then would have a look at these range of studies and come with information, right? And maybe it's a question for him, but like from your experience in this, is there been a situation where you've like, hey, I know that XY drug isn't as effective as they're saying, or I've found out this information based off other studies, but it's what the doctor prescribes, or it's what again, the doctors are just fed information, whatever they've been told, right? I don't expect a doctor to do the meta-analysis, but somewhere along the line they fed the wrong information. Something you've picked up because of what he said, or something you've anecdotally picked up. What happens there? Like, do you tell the client, hey, I know this may not work, or?
It's a very fine line, right?
Yeah.
I can't step on the doctor's toes,
Yeah.
and the doctor's free to prescribe what they want to, right? So I have to it is a linear chain of command. I have to follow their orders. That's what a script is, basically. It's an order at the end of the day. But I think it may be important to have that dialogue. This may not be the right, or we're not seeing an improvement here. What do we do? If someone comes in, their blood sugar readings are 12, 18, just very erratic. You look at their medications, it might be the latest and greatest thing on the market, but it may not be for them.
Yeah.
So at what point do you intervene? At what point do you go, I think it's time to see an endocrinologist? But I can't have that direct line, so it's very, it's frustrating. It is.
I bet it's frustrating.
I wish I could sit there and go, mate, there's 3 other things on the market that may work for you, but I can't sit there and...
Yeah. And I get that that's a difficult position that you're put in, but it's just, I guess from an end consumer point of view, like that's like, I just think that it's confusing, right? We're taking, and we said obviously because we want instant fixes, right? So that's maybe where the problem starts, but we're taking something that we think is going to help us. We then go down the path where the person that told us this doesn't know any better, but this medication was never going to help me, right? And then maybe things get worse, maybe things get better, or maybe it throws something else out and I get side effects, but hey, I just took it because doctor told me.
Implicit trust, right? Yes.
Yeah, that's just a little annoying to kind of...
As a consumer, absolutely. If I was in that position, I'd be like, well, I don't trust anyone now. I don't trust anyone's decision. I'm going to take healthcare into my own hands in a way. I'm going to seek out.
That's right.
Which
see a lot of that.
isn't the answer either.
No,
right?
exactly. It's not the right thing to do because
if
you need
you've
some
got
sort of medical training to make an informed decision. But then
Yeah, if you've got a problem, if you've got a health problem, you need some sort of intervention. So taking it into your own hands isn't the solution either, right?
Exactly.
But yeah, like, and I know we're talking about a small section. I know this may not happen en masse, but it seems to be happening more than maybe before.
Correct.
Like, I don't think when I was a kid, anyone ever questioned a doctor.
No.
And I know that maybe social media has changed that view, but it's not like those views are wrong. You know, social media maybe picks out one small thing, but then it turns out to be true.
Yeah.
Like, so it's not social media's fault, and I'm not saying it's the doctor's fault, but somewhere along the line we were fed bullshit from the start.
Correct.
That's the hard part.
Then I think that's the hard pill to swallow. No pun intended. That everyone has. You know. You sit there and go, fuck, I've been taking this for years. And, you know, like you see adverts in America all the time. You know, they're pumped ads all the time. It's ridiculous. Yeah. You listen to this new side effects, mate. You're sitting there going, that's 45 seconds of just side effects. Yeah. And then 2 seconds later, it's like, have you been taking this drug? You're like, well, shit, you know, lawsuits waiting to happen, right? So it is for absolutely.
Yeah. Have you ever watched American TV?
Yeah, it's insane.
I don't know if you've ever seen it, but they're allowed to advertise pharmacology. But then not only that, then the next would be the lawyer putting up a class action lawsuit
against the drug that was just listed.
Company that you were just watching. Like, that's the fucking crazy part.
It's insane. Yeah. Like, you know, ads of 3 minutes, and half of it's just like, oh, have you got joint pain? Yeah. Have you considered taking this? Speak to your doctor about this. And then side effects may be, and they're just speaking this low monotone voice. You're like, no one's going to bother.
No one's going to bother.
But everyone's heard, I've got joint pain. I'm going to go see my GP. You know, I'll give it a crack.
That's part of advertising.
Yeah, that's it. Exactly. That is advertising space, right?
That's advertising.
And then,
America, the fact that America can do that, and New Zealand can.
New Zealand, well. They can.
So, but you know, apart from those two countries, no one else does it. There's clearly a reason, right?
Yeah.
But then
scares the shit out of people.
It scares, but not as it scares the shit out of people.
It just sways people's decision.
Exactly right, because they're good at if you're good at marketing,
you're set.
You're set because it doesn't matter what you're selling, it will work.
It will work, exactly. Right? I could drop ship water bottles, for example, but if I make it the best thing since sliced bread, I'm gonna make $10 million. I'm set, you know. Exactly. So,
but it may not be the best product. No, it's how you sell the product.
It's how I sell a product.
Yeah, that's. But that could be happening in pharmacological space. Well, it is happening in a way.
Yeah. Right? I mean, I see the end product as we said right at the beginning. I see the end product. I may not see the behind the scenes from conferences down.
Yeah, correct. Interesting. Now, I think the three of us can keep talking forever, and this is a really important topic to discuss. And we've obviously got Michael here, who's, giving his time to talk all things pharmacology and in that space. So we've split this podcast into 2 episodes.
Just as well, because I need a break.
Yeah, Harry's brain is fried.
Oh my god.
So we'll be back with more in the next episode.
Stay tuned.